Okay. All right. Well, thanks everybody for joining. We may break a little bit from our academic format to do a few case reports. So we'll see if I may pull up our questions. Let's see, where is that? Potentially, if y'all want to kind of stop me at some point, if you have any questions about our case, feel free to kind of jump in. And so I've got two cases. After we get through our obstetric cases, Dr. Oliver and I are kind of go through our approach to placenta accretas and our cesarean hysterectomies. And hopefully that'll be kind of useful for you guys. So our first case, this is Miss TM. She's a 24-year-old G1, and she was referred to us at 20 weeks. She had her normal anatomy scan at her primary obstetrician's office, where they identified what appeared to be a fetal omphalocele. And so she was made aware of that suspicion and arrived at my office at 20 weeks. And so I've got some pictures from our images. And so didn't necessarily go through the definitions of omphaloceles versus gastroschisis, but happy to kind of point a few things out. So an omphalocele is a defect in the abdominal wall. And so the two main abdominal wall defects that are found are omphalocele and the gastroschisis, and the identifying portions really between those is two main items that you can see on ultrasound. The first is the location of the defect. Gastroschisis is typically located not at the level of the umbilical cord and to the right. And so with an omphalocele, it is at the level of the umbilicus and the abdominal cord insertion of the umbilical cord. And so you can actually see the umbilical cord directly insert into our defect. The other identifiable ultrasound finding is the presence of a peritoneal covering. And so we can somewhat see this here in our defect, in that this is our defect here. We're seeing a portion of the abdominal wall. We can see a lower extremity here and the beginning of a lower extremity here. And so this is our defect, and we can see a peritoneal covering that surrounds this. So this is not free floating. So that's what helps us differentiate that this is not a gastroschisis, and this is in fact an omphalocele. On our picture on the right, we can identify our abdominal cord insertion of our umbilical cord as it directly inserts into our defect as well. And so this is definitively an omphalocele. But this is not an isolated omphalocele. And so omphaloceles can be related with genetic disorders. And so certainly whenever any defect is identified, an entire targeted anatomic survey is indicated. And so in addition to our omphalocele, we identified what appeared to be an abnormal spinal abnormality. And so whenever looking at the spine, we attempt to find this particular sagittal view here, in which we can identify these, our normal railroad of our pictures, we can see here, and then identify normal skin edge above. And so the skin edge is fairly normal, but we can see a pretty sharp demarcation as we start to enter into the lumbar spine. And while this may not look necessarily abnormal just looking at it, when you're looking at spines all day, you can tell that this is a definitive abnormality, albeit difficult to diagnose at 20 weeks. She also had what appeared to be right renal pyelectasis, or an excess of fluid found within the kidney. And so she was counseled at this point. Certainly the presence of the omphalocele is important, but once we start to add additional defects, again, we know that omphaloceles can be related to genetic abnormalities, that the risk of this having a genetic or chromosomal cause is increased dramatically. The other interesting thing, and I'll go back to her omphalocele pictures, and it's difficult to demonstrate on 2D pictures, was the location of this omphalocele. So again, an omphalocele, if you can kind of imagine, is directly at the level of the umbilicus. So well, we all have a belly button, so you can kind of imagine where that should be on a baby. This omphalocele is low. So the defect appeared to be too low than normal. Probably best seen again on a sagittal picture, and again, difficult to identify on 2D imaging, was that the defect was lower than expected. And this made me concerned that this was not a simple omphalocele. She did not want to undergo an amniocentesis at that point, but she came back about a week later and underwent her amniocentesis. And so we sent that off for our typical workup. The initial karyotype rules out our trisomies and kind of obvious pictures that we can see off of our immediate testing. We get that back in about 48 hours. That was normal. Sent it off for a microarray as well. That was also normal. And came back for XY. So this was a male fetus. She then underwent an MRI, the suggestion of our colleagues, because of the inability to kind of confirm the sex of the fetus. And that showed the atypical omphalocele that was really below the level of the umbilicus, although it did include the abdominal cord insertion. It showed unilateral renal agenesis and the pyelectasis, which we had noted. The bladder was not able to be visualized, and of course they identified the spine as being abnormal as well and suspicious for an OEIS complex. And we'll go over what that is here in a few minutes, or immediately right now. So we like to use a bunch of letters in obstetrics. So the O, and this is of course the omphalocele that we've been seeing. The E stands for extrophy, which in our case is cloacal extrophy. I is for imperfect anus, and spine is for spinal abnormalities. So of course, our child fits pretty much all of these. This was first suggested back in the 70s by Dr. Carey, who was able to identify several children that exhibited these all of these findings. So the omphalocele, we'll start there. So it doesn't actually have to be present for the entirety of the case. If you look in the literature, there are children that are identified as an EIS. Some of them just have the IS with a portion of the extrophy component. So not involved in all cases, but it is the herniation of the bowel that occurs between that cloacal extrophy and can be described as what we call the elephant trunk sign, depending on how the umbilical cord is laying in our pictures. The next is the extrophy, and so that's going to look a little bit different depending on the sex of our the fetus. So, but essentially, this is a hemibladder where the bladder is existing outside of the body, so there wasn't a closure of the entirety of the abdominal wall. And typically is going to contain the ureter, the vas deferens, the orifices within the males, or the uterovaginal canal in females. And depending on the level of the defect can depend on how complex the case it is. It can be on the more simple side involving an epispadias. It can be bladder extrophy that's somewhat isolated, or it can be entirety of cloacal extrophy, which was the case in our patient. Lastly, thirdly, so the imperforate anus, there's an absence of meconium that's able to be identified filling up the rectum and colon. And so sometimes we can see that at ultrasound. MRI can detect that on the T1 mode. Typically meconium has a high signal intensity. And so she actually had a second MRI that was a little bit later in gestation, was able to accurately identify this baby as having an imperforate anus as well. And then our spinal abnormalities can be somewhat broad depending on the definition. Club feet can be present in up to 50%. The myelomeningocele, you can see that wide range of percentages on its presence. Our child did not have a myelomeningocele, nor did it have a full segmental defect. What we were visualizing was a hemivertebrae, and this was confirmed postnatally as well. So the differential diagnosis, always important. What is this specific case going to do for maybe the general OB or somebody that's kind of listening here? I suppose whenever we see an isolated omphalocele, always important for these kiddos to have that targeted anatomy scan to look for additional defects. But certainly could be just an isolated omphalocele. Could also include an amniotic band, abdominoschisis that can cause multiple defects in a located area. Body stalk anomaly, which was not our case. That's identified by a twin a singleton that's stuck next to the edge of the uterus. Or potentially we're visualizing a bladder extrophy versus the omphalocele component. So this is pretty rare. a 1 in 200 to 400,000 births. So potentially the only case that anyone from our facility may end up seeing. And actually fairly decent outcomes for these kiddos. So 70% are live born, about 15% stillborn, and that's often related to the severity of the omphalocele defect and what organs are involved. And then about a 13% termination rate in the studies that have been completed. So again, this was identified specifically back in the 70s. In the 60s, when we looked back, 100% mortality in children that were born with these defects due to the complexity of the closure that's required. Once we were able to figure out how to close some of these defects and provide better care, survival's greater than 90% for those that are going to make it to live born surgical intervention. That being said, those survivors require a number of surgeries, and there's also a number of psychological and psychosocial consequences that are related to the sexual function and determining how those children are raised. One of our issues that we ran into here was her location for surgery. For this specific case, it was a bit complex in that we decided that she should probably not be delivered here at our facility just due to the rarity of these cases. There's only a few centers really of the world that take care of this on a routine basis. And so we attempted to send her up to a location up in the Northeast that didn't work. And long story short, we were able to pull a few strings from our urology division. So shout out to those individuals that were able to get her up to the University of Colorado, which is ultimately where she delivered and then had her surgical repair. So this is our neonate that was born. And so this is our picture of our defect. This is our omphalocele. And as we can see, our cord directly inserting into our defect with a peritoneal covering. But then the cloacal defect that we can observe. And then the abnormal genitalia. As you recall, this is an XY male. And so trying to determine what structures are phenotypically present compared to our genotype was difficult. And so here's kind of a zoomed in picture of some remnants of the genitalia that we see, as well as the hemibladder that was able to be closed. So they were kind enough to send us some intraoperative pictures. So these are pictures of our colon and intestines. And so ended up having some of these removed. And again, we have an imperforate anus, so it requires an ostomy to be placed. And so these are some additional pictures. And so they were able to get some amount of ureteral access to provide leakage so that they can drain the bladder that they were able to put back. And so this is our post-op picture. So able to completely close our abdominal wall, which is great. So left our remnant of umbilical cord for venous access, able to completely close our omphalocele defect. They were able to internalize the bladder and complete the closure there, allow for an ostomy as well, and then drainage for our bladder. Again, these children are going to have significant psychosocial and sexual difficulties as these children grow older. The previous treatment for a lot of these individuals that were XY that did not have a significant amount of external genitalia were converted to a phenotypic female and raised as females. And over the last several years, they've kind of determined from our outcomes that it's probably better to let these individuals continue to grow and then determine how they're going to raise these individuals later as they mature. And so that's her case. So this was pretty interesting. I'm going to see if I can pull up some questions. I don't know if anybody have any specific questions related to this case. And if not, we'll move on. Our next case, and these are references in case anybody wants any access to some of those case reports that are done. So our next case is Ms. KW. So she's a very interesting patient as well. So she's a 26-year-old G2 P1001. She presented in my office at 21 weeks, and essentially she was sent because there was discrepancy between her cell-free fetal DNA results and ultrasound findings. So cell-free fetal DNA, which is what the NIPT is referencing on the screen, is a way to detect chromosomal analysis and allow for some form of genetic screening in our pregnant population. What that looks at is what we would call cell-free DNA. So we all have cell-free DNA floating around in our bloodstream as our cells go through some amount of apoptosis. That being said, only our pregnant individuals have cell-free fetal DNA floating through the bloodstream. And so we can draw a tube of mom's blood, send that off, detect the fetal component, and screen that blood in a few different laboratory methods to screen for items such as trisomy 21, 13, and 18, a few microdeletions, and also sex chromosomes. So oftentimes our population may choose that test specifically for the sex chromosomal analysis, and they're pretty accurate. Girls are XX, and so typically our pregnant population will be XX, and therefore the presence of a Y chromosome on that NIPT will allow the detection of a male fetus. And so occasionally we'll find some sex chromosome discrepancies on NIPT, and I think I've got a slide in here that talks about our differential diagnosis when that might occur. But she was told that she had a male fetus, and of course, this being 2021, underwent a significantly large COVID-appropriate Facebook Live video with her closest couple hundred family and friends to let them know that she was having a boy. She then underwent an ultrasound for her anatomy scan and was told that she was having a girl. And so there was a discrepancy, and that's how she presented to our office. So on her initial scan, it did appear that this was a potential female phenotype. She also had mild polyhydramnios, so unilateral club foot, as well as bilateral pyelectasis. There's some dilation in the renal pelvis. And so we had a discussion. Again, you're kind of allowed maybe one strike, maybe two strikes, but not necessarily three or more whenever there's a sex discrepancy. And so she was counseled on the potential options, and she elected to undergo an amniocentesis that would first initially just tell us, is this a male or a female fetus, and then what else is going on. So these are her initial pictures. So some decent dilation for this early in gestation for both kidneys. And then when attempting to look at the genitalia, trying to decide if this is a phenotypic male versus female. And so on initial look, kind of a classic 3 lines, would agree that this does look like a female, although perhaps some virilization larger than expected for this gestational age. So in the initial result, we got our karyotype back that confirmed fetus is in fact XY. About 10 days later, we received her microarray that looks at some microdeletions and other panels that came back negative. And she was counseled to send off a panel that includes a number of diseases that might be present for sex chromosome abnormalities, which also included a few of our skeletal dysplasias. The majority of those are extremely rare, but she did elect to undergo that. And unfortunately, hers came back positive for a variant at the SOX9 gene that's consistent with the diagnosis of Campomelic dysplasia. And I'm assuming that probably doesn't ring a bell for anybody because of its rarity. So what is Campomelic dysplasia? So it's about 1 in 40,000 to 1 in 200,000 cases. There's about 100 case reports that have been written up in literature. It involves the 17th chromosome, and a majority of the mutations involve the exact SOX9 gene. There's a few mutations that are just outside of this gene location that can lead to some mild phenotypes. It's considered an autosomal dominant mutation, and therefore this would be a de novo mutation. And of course, both parents were were screened and were negative for any mutations there. So what is it? Campomelic dysplasia can lead to bowing or angulation of the long bones. There's typically only 11 instead of a set of 12 ribs. Leads to underdeveloped pelvic bones and shoulder blades, can lead to abnormal skull shapes and abnormal facies, lead to ambiguous genitalia and clubbed feet, which kind of matches up with our patient. But our patient does not necessarily have the other anomalies that you see here. And so this is often, unfortunately, a lethal condition. Difficult to say that this is 100% lethal because it's not 100% lethal. Most newborns do pass away, unfortunately, shortly after delivery, but it does not follow a typical skeletal dysplasia pattern. So often what we would identify as a lethal skeletal dysplasia, and kind of to back up, there are hundreds of skeletal dysplasias out there. So if you were to go find a book on skeletal dysplasias, it's extremely long, extremely thick. But typically we identify them as lethal or non-lethal. And lethality, we attempt to predict prenatally based on the thoracic cage hypoplasia that leads to lung hypoplasia that inhibits these little ones' ability to oxygenate after delivery despite our medical attempts to help them out. And so we can somewhat reliably predict lethality in skeletal dysplasias. This one in particular does not follow that pattern. And so these individuals actually don't have a typical, what we would identify as a bell-shaped chest or a small chest. They don't have lung hypoplasia. Unfortunately, these little ones die of tracheobronchomalacia. And so despite our best efforts, they often do pass away from that. Let's talk about, why is this important? And I thought this was an interesting case because the idea of sex discrepancy between an NIPT, which a good portion of our patients are going to undergo. When is, what should I be doing? What should our OBs be doing, our nurses and that sort of thing when there's a sex discordance? So I thought I'd at least throw out a few of our differential diagnoses that might exist. The top one is undiagnosed twins. So our tests are better at this now, but in the event that we had an early loss of a twin, if there's still placental tissue from an XY dichorionic diamniotic twin that's present, then they would potentially still pick up that Y chromosome portion in mom's blood. That would lead us to a false result. Now, we're more sophisticated than that now. This technically shouldn't happen. Because they can tell us what we would identify as the fetal fraction, and that percentage should be off, and they can actually mostly tell us this difference. The remainder of the differential that you can see here are other items that would lead to sex discrepancy that's found in our phenotype. So for our boys, we might find hypospadias or disorders such as Smith-Lemli-Opitz. For girls, they can have congenital adrenal hypoplasia. Chromosomal abnormalities such as trisomy 13, Noonan syndrome, Cornelia-de-Lange, Prader-Willi, Charles syndrome, or as we previously noted, our OEIS cases or cases of cloacal exstrophy. And that's her. She's actually due to deliver at our facility, and our hope is for the best. She actually has a somewhat atypical approach in the sense that she has a campomelic dysplasia, meaning that we actually don't see the bowing of the long bones. And so despite her having the SOX9 mutation, we're hopeful that without having the long bone abnormalities, that perhaps this is going to be one of our kiddos that's going to make it and be hopefully reported in literature. Any questions? And as we're waiting, Dr. Oliver is going to come and kind of lead us in our discussion about accretas.
Yeah, so for those that were able to tune in at the beginning, Dr. DePasquale had mentioned one of the things that we're pleased about here at Erlanger is kind of the multidisciplinary approach that we can apply to certain situations. Thankfully, Dr. Gonzalez and I don't have to coordinate with each other too much. No one wants the oncologist coming by, but occasionally there are certain circumstances where we do need to. And one of the most common for us is with placenta accreta. And so we'll have a little discussion about accretas, how we approach those, and would definitely be happy to answer any questions that come up. So can you tell us a little bit about placenta accretas, what the definition is?
Sure, yeah. And so for normal placental function, the placenta does attach to the uterus via some spiral arteries, but there's a layer that exists between those two. And so after delivery, we should see the ability for the placenta to be separated easily from the uterus itself. And so the way I kind of try to describe this to the residents in some sense is that if there's some amount of poor oxygenation status, I try to think of the placenta as a root system. And so if we're not getting enough oxygen, then that root system is going to dig deep. We have a good amount of oxygen, and that root system can stay nice and shallow. So that's what we want. We want a healthy formed placenta that's in the right location. And so with an accreta, it's going to involve potentially a poor location or a poor placenta that's now been required to dig deep. That root system has to dive into the uterine tissue, that musculature. And now, instead of being able to separate after delivery, those vessels are intertwined inside of the musculature, and that's how we get the placenta accreta spectrum.
And one of the things that we see is as the rates of C-sections have increased, we're obviously seeing more and more of these accretas diagnosed. Can you talk about when they're typically diagnosed and how you diagnose them?
Yeah, so from our side of things, the best way to diagnose these initially is on ultrasound. But I think that the most important part of this is having a high degree of suspicion. So you mentioned cesarean section. So risk factors for an accreta, include uterine operations. And the most common for those would be cesarean sections, but it would also involve DNCs or myomectomies. And so a high number of operations should increase our suspicion that there's going to be some level of abnormal placentation, and also the location of the placenta itself would also increase my concern. And so the presence of what we would identify as a placenta previa, where the placenta is covering the internal cervical os, is going to increase that, as well as its location related to those procedures that have been done. For example, cesarean sections are typically performed on the lower uterine segment on the anterior portion of the uterus. And so that location would be concerning. But if they happen to have had a myomectomy that was posterior or fundal, that location would also be concerning.
And then as far as managing the pregnancy, are there changes in how frequently you do ultrasounds or neonatal testing or?
Yeah, so the bulk of our conversations, of course, probably lead us into the delivery component. But again, we're dealing with a placental dysfunction, and so a higher risk of growth restriction, higher risk of having this abnormal placentation lead us into abnormal, Doppler flow, oligohydramnios, et cetera. And then delivery location and timing are such a key point. And so we spend a lot of time counseling about vaginal bleeding, what we would consider pelvic rest, as well as preterm labor, preterm contractions, and that sort of thing.
Yeah, you mentioned, bleeding during delivery. And I think that's one of the most important things that we can stress for this is this multidisciplinary approach, an attempt for a planned delivery versus an emergent. Sometimes these aren't found on ultrasounds, and we don't know until the time of delivery. But oftentimes they are. And when we talk about the different kind of teams that can be involved, we obviously have the OBGYN and the MFM team. Oftentimes GYN oncology is involved for the time of the hysterectomy. And then occasionally we need to make sure that urology knows, especially if we're planning on doing a bladder resection or maybe having to reimplant the ureters, and then our interventional radiology colleagues at certain times. too. As we were talking, you mentioned kind of different techniques intraoperatively to potentially think about. Do you want to talk about maybe some of those that you've had experience with? Or
there's several groups that have kind of attempted to put together research as well as publish their data on what works and what doesn't. I think the number one factor for what works is a planned, what we would identify as a cesarean hysterectomy. So we don't remove the placenta at all. We basically perform the cesarean section and then perform a post-cesarean hysterectomy. And so the number one thing is to identify it ahead of time in the antenatal period and then proceed with a planned delivery, because that's going to decrease all of our main complications. So those main complications are blood loss requirements for transfusion, needing to go to the ICU, the length of time, infection, and length of stay in the hospital for both mom and baby. So essentially every one of those quantifiable factors are reduced by an antenatal diagnosis, number one. And then number two, it would be saying, okay, what specifically can we do maybe right before the procedure is getting started that can reduce some of those? And there's a number of methods that have been attempted. One of those for our surgeons that are here would be the placements of uterine balloons. So the idea is to occlude uterine artery flow to decrease blood flow. And so we've attempted to have interventional radiology place those ahead of time, but we don't inflate the balloons, perform the cesarean section, and then immediately inflate those to decrease blood flow to the uterus. It sounds great, sounds super cool, sounds super fun, doesn't work as well in the real world. And so essentially we're probably adding some amount of risk factors to mom without getting a lot of benefit. So I typically don't offer that to my patients unless perhaps there's something else going on. I think we had talked about the other probably big, maybe a pre-cesarean section method is the placement of some amount of catheter system to allow for us to identify our ureters. And so we place stents into our ureters to identify those better for surgery. Not necessarily something that we do for every case. The data kind of goes back and forth on those. And so if we think that there's going to be bladder involvement, then that's where we'll have oncology go ahead and place those ahead of time so that we can better identify those structures.
And you had mentioned too, you had some experience with a stapling device that sometimes you use for exit procedures, but
yes,
you use them for cesarean hysterectomies too.
Exactly. The whole goal of our procedure is to get out of the OR as quick as possible, reduce our blood loss, and that's going to really improve again all those factors. And so a typical C-section blood loss expected would be somewhere between 500 and 1,000 milliliters. And so if the hysterectomy component of our C-hist is going to add some liters to that, my question is, how can I reduce that from a cesarean perspective? And so can extrapolate from what we would call an exit procedure. Those are procedures where we have to deliver the baby, but maybe leave them attached to the uterus for a significant amount of time. And we can use a stapling device to enter into the uterus that limits our blood loss to fairly minimal. And so what I try to do for a planned C-hist is use a GIA stapler to perform the actual hysterotomy itself. And what that allows us is to reduce our blood loss from the cesarean component of the C-hist from 500 to 1,000 down to probably under 100. And so we save ourselves almost a full liter of blood loss before we even get started. And that's going to improve our outcomes.
That's a great technique. So it sounds like, the most important step is early diagnosis. So having a high index of suspicion for someone that's had, multiple C-sections before, if they've had, uterine procedures for something else. So high index of suspicion for that, diagnosing it antenatally, trying to see if there are any indications for increased fetal monitoring during the pregnancy. Mm-hmm. Definitely having a multi-team approach by getting kind of any available services coordinated beforehand for planned delivery. And I think you mentioned a few times, I forgot to mention earlier, definitely having the blood bank notified because these, you can have a pretty significant amount of blood loss with these. Again, trying to have a planned delivery and just a kind of a smooth, calm process throughout it.
Yes. Well, we actually had a case just a few days ago where we had an unplanned, somewhat unplanned cesarean hysterectomy. Can you, and have an oncology there is helpful for the routine obstetrician. Can you walk us through kind of your technique for your typical CHIS component on where do you start? What blood supply do you attempt to control first, et cetera?
Yeah. With these, they're just like our other abdominal hysterectomies, and the fact that a larger incision is made, the uterus is usually brought up through that incision. Oftentimes, there's no need to remove the ovaries at this time, so we try and conserve the ovaries if at all possible. And so we'll start off by removing the fallopian tube attachments to the ovaries, and then going through a stepwise approach, just like we do with a traditional abdominal hysterectomy. There are a few things that can make this a little more complicated compared to a non-cesarean hysterectomy. And that is, as you mentioned earlier, the pregnant uterus is obviously very hypervascular. So even our standard vascular pedicles that we take, there's either more of them or they're significantly dilated compared to a non-gravid uterus. And so we usually have to do a combination of either using like a bipolar vessel sealing device in combination with suture ligation. Sometimes the pedicles are too large for those bipolar devices to actually seal the vessels. And so we rely more heavily on making pedicles and not tying than we might do otherwise. So I would say that the same techniques are still in place, stepwise process, but that's why we see that increased bleeding is just because of the dilation of the vessels. The other thing that we can run into, especially if someone has been laboring for a little bit of time, is sometimes it's hard to identify where the cervix and the vagina meet. And so it can be difficult to do a total hysterectomy in removing the cervix and the uterus. And sometimes a portion of the cervix is left behind, but we try and remove it all if at all possible.
I think another thing, in case anyone's decided to go do some literature research on the newest data on placenta accretas and CHIS, is there's a technique where the question is, can we leave everything in situ and actually avoid a hysterectomy? And so some of that data comes from maybe abdominal pregnancies. So some kind of an odd abdominal pregnancy that escapes detection. And so we have maybe a preterm delivery of a viable infant where there's a placental attachment to other organs. And the large intestine has been identified there. So we don't necessarily want to go in and remove all of those attachments. It would be fairly impossible really to do that. And so those have been treated successfully with the use of methotrexate. So deliver the baby, leave the cord and the placenta in situ, and then give methotrexate. And that's actually been successful for abdominal pregnancies. So the question is, can we do the same thing with the uterus? Maybe even preserve the uterus if the mom wants to. And so there are ongoing trials that have looked at that. And some of the results are mixed. One of the risk factors to describe that procedure somewhat basically is you still perform the delivery of the fetus, clamp the umbilical cord, tuck it back inside of the uterus, and then close the uterus in our normal fashion while leaving the placenta still attached to the uterus. And then giving us maybe 4 to 6 weeks of time for that uterus to clamp down, to involute. What it does is it allows all those vascular pedicles that you're mentioning to shrink down to a normal size. And the idea is that it would potentially lead all those blood loss opportunities, the ICU stays, et cetera, the need for blood products to decrease dramatically, and then maybe go back in at 6 weeks and perform a hysterectomy then, or to even give methotrexate and allow normal, maybe not normal, but allow the mom to preserve her uterus. Again, mixed results. Some of those ladies have done extremely well. Some of those surgeries have gone extremely well. There's also a high risk for infection. And so the women that do have an infection have a risk of doing extremely poorly. because now you took a difficult surgery and now they're infected. And so that gives us some increased concern. So those are ongoing studies that we'll probably hear back more as we get through a couple of years worth of data.
Yeah, but it is an exciting possibility, especially for patients that aren't done carrying children that want that opportunity. And like you said, definitely close follow-up on those, because there is a very high rate of hemorrhage, infection, and ultimately needing a hysterectomy. And so it would definitely keep a very close eye on those patients and have that kind of multidisciplinary approach for that. Kind of along those lines are, we see this in molar pregnancy some, and some research with this. I spoke some about immunotherapy earlier on this morning, and molar pregnancies that are refractory to methotrexate or other chemotherapy regimens. We've actually seen that there are some immune checkpoint inhibitors that are very good at treating those conditions. And so there's a possibility of using those with retained placenta as well, which makes sense because the placenta is kind of the ideal model for studying how the immune system gets blocked. The placenta being a foreign body or foreign object, yet it doesn't get attacked from the immune system. So can immune checkpoint inhibitors kind of play a role in that? And they might play a role also in these accretas with placentas that remain in place.
Fascinating data. I suppose one of the other techniques to mention, depending on really if a mom really wants to have preserved uterine function, is what can be called the triple P procedure, where essentially you attempt to remove the healthy component of the placenta. If you think that maybe there is what we would identify as a focal accreta, where there's only a small portion of the placenta that's ingrown into that uterus, is we can cut that portion away, remove the healthy portion of the placenta that separates well, and then perform some form of a wedge resection at that area where that focal accreta is, and then sew that area back together, essentially removing that abnormal placentation. And then that would potentially preserve fertility as well. So there's several studies there. I think we're getting close to the end. I have a question for post-op care. So for me, I'm not entering the bladder as something I attempt to avoid as well as I can. And so it's not something I deal with all the time. Can you give us maybe some words of wisdom on when you close versus leave the bladder open, depending on how big maybe a rent is that's identified in the bladder, and then what you recommend for Foley approach, depending on the size as well?
Yeah, so typically any defect that's gone through the serosa and muscularis layer and entry into the bladder, we attempt to reapproximate that, typically doing a 2-layer closure of delayed absorbable suture. And then we'll typically leave the catheter in place for a couple weeks just to prevent any significant distension to allow that suture line to completely heal up. And then depending on the size of the defect, oftentimes we'll get a voiding cystogram a couple weeks afterwards, just to make sure that that's completely intact. Especially because if you're doing a hysterectomy at the same time, they're at an increased risk for a fistula formation. And so making sure that that defect is completely healed before the catheter is removed. I haven't had to have anybody that's had to keep the catheter longer than 2 weeks. Usually the cystogram is, it shows that everything is watertight at that point. I don't know if there's any questions that have come up on the chats. We're happy to take any.
How much does their risk for an accreta increase with each C-section?
Yeah, that's a great question.
Where are the residents?
I know. Yeah, no. I think I saw at least 3 of our three chiefs logged in. Maybe they can respond on our question mark. No, so it definitely will increase. The real data comes from the presence or absence of the placenta previa component. And so again, that if you take that kind of theory of the tree root system, a placenta previa, the cervix itself is not going to provide enough oxygenation for that placenta. And so having the previa by itself is actually going to increase our risks for an accreta above just having a single cesarean section with, let's say, a posterior placenta that's well away from that prior uterine entry. And so there's an exponential increase. If there is a placenta previa, there's an exponential increase based on the number of C-sections that a patient has had, upwards of 67% for someone who's had 3 or 4 cesarean sections.
All right, wonderful. Well,
thank you.
Can you come up? Yeah. All right, thank you.
We will take a 15-minute break and come back at 1 o'clock for the next speaker.